This video series contains scientific and medical concepts aimed at informing healthcare professionals. Please note that the videos may contain visually stimulating images and movement.
Clinically, it remains critical to remember that PEM is perhaps the most debilitating and miserable aspect of the entire spectrum of ME/CFS as an illness. It has been postulated that the neurophysiological responses taking place during PEM may accrue over time, leaving a permanently altered function or injury upon exceeding some threshold of frequency and intensity of these effects. How then can we, as clinicians, manage this particularly insidious and simultaneously deleterious aspect of this illness?
The answer appears to be, at its most simplistic, through a careful regimen of both physical and cognitive pacing, so as to avoid entering the physiologic state we describe as post-exertional malaise. Fighting or pushing through the physiological thresholds of this illness consistently proves to be a fool's errand, often resulting in greater degrees of functional impairment and illness progression. Forcing continued, repeated, and exertional exercise to combat an underlying decompensated state, while logical at first glance, only appears to tragically promote worsened long-term outcomes.
Consider a stubbed toe. Slamming a toe with force into a doorframe may not be a particularly pleasant experience, but if given time without repeated injury, this toe will more than likely heal. Now consider a situation in which a person continues to stub the same toe repeatedly each and every day, or alternatively, once every 1 to 2 weeks for the next 10 years. Might there be a more permanent injury or scarring with this toe? It appears, upon a metaphorical level at least, that the same concept of injury and permanent alteration of structure and/or function may be true with post-exertional malaise.
A patient does not manage this illness by fighting harder, but instead by acting with discipline and calculated intelligence so as to prevent episodes of post-exertional malaise.
Strategies for pacing can be employed in many forms. Patients should be encouraged to take frequent restorative breaks within the context of even one particular activity, rather than completing a more prolonged activity and then resting for the remainder of the day. Setting timers during activities can be of enormous impact to this end. Wearable devices that track heart rate may alert a patient to heart rate increases that suggest physiological stress with an activity prior to onset of symptoms resulting from this physiological stress. Activities can be modified to reduce overall physiological stress. Consider suggesting that patients sit or keep their legs elevated when performing activities they might otherwise be inclined to perform standing, especially in those who suffer from notable orthostatic intolerance. The use of a simple shower chair can often mean the difference between an episode of PEM or a restoring shower. Remember that cognitive exertion need not be completing difficult algebraic calculations. In fact, cognitive exertion can often be the result of processing multiple sensory signals at the same time. Consider a person having a conversation in a crowded restaurant, dishes clanging, music playing, multiple conversations taking place, and delicious smells wafting through the air. While healthy people might find that maintaining a conversation with the dining guest in front of them may be easy, sorting through multiple sensory inputs to pay attention to one particular signal remains a particularly energy-demanding task. Reminding patients that particularly stimulatory environments alone can be enough to overwhelm their cognitive faculties can often be invaluable advice. Even emotional responses, be they excitement when opening a gift or mourning the loss of a good friend, can be a triggering event for post-exertional malaise, unavoidable as these triggers may be. While pacing remains the cornerstone for management of PEM and for ME/CFS in general, low doses of the opioid antagonist naltrexone have shown pharmacological promise. Low-dose naltrexone, or LDN, has been found to modulate microglial cells, perhaps through toll-like receptor 4, to suppress transition from resting state to an activated state in which pro-inflammatory cytokines are released. LDN is a widely used off-label treatment within the field of ME/CFS, seemingly increasing the physical and cognitive threshold for induction of PEM, shortening the duration and symptomatic severity of PEM episodes, reducing levels of widespread pain amplification and sensitization, and/or promoting an improved sense of well-being among a subset of patients suffering from ME/CFS. Finally, many medical providers have found it useful to remind patients that successful clinical interventions, say, to improve orthostatic intolerance, might improve a patient's overall feeling of wellness.
This sense of wellness can be subtle, but may still allow someone with ME/CFS to do more than they usually might be capable of. They may find themselves exuberant in a short moment in which they feel healthy or try to make up for lost time. Though these reactions are inherently human, they may cruelly still be enough to trigger an episode of PEM. Both care providers and patients alike must keep this concept in mind when assessing the actual efficacy of any intervention made to improve the symptoms of those suffering with this devastating illness.
Ultimately, it is critical that healthcare professionals and patients recognize PEM and work together to interrupt a repeated push-crash cycle. It has been consistently observed that when patients finally break this cycle and avoid PEM for a more consistent period of time, their functional baseline and all aspects of their ME/CFS symptom control improve, independent of any other pharmacological or behavioral intervention. Managing each and every pathological component of ME/CFS not only reduces the impact and suffering of those specific symptoms, but perhaps more importantly, can reduce the incidence, duration, and intensity of PEM and improve overall function and prognosis.
This video was made possible by the OMF-funded Medical Education Resource Center at BHC, our generous donors, and viewers like you. Please consider making a tax-deductible donation to help keep educational resources like this one publicly available.